So good morning. Welcome to PCEP for August 2023. Today we're going to talk about geriatrics. The things that I want to get across today, we're going to go through the physiologic changes that happen in the elderly, and we'll go through that by system. We'll talk about iatrogenic risks, in other words, the stuff we as doctors do to people that puts them at lower risk for some stuff, but a higher risk for other stuff. And then we'll talk about practical approaches to caring for the illness and injury in the elderly. So I'm going to start off by just giving some context about how big a part of geriatrics is in our practice and why we run into the issues that we run into. So this is probably no surprise to anyone. This is, if you look at life expectancy, in 1860, life expectancy in the US was about 40 years. There's a drop during the Civil War. And then there's been essentially a gradual increase since then. So, as a rule of thumb, when we talk about the elderly, we're talking about people greater than 65. And so the proportion of those in the population has decreased dramatically over the last 150 plus years. This is the big part of what we do, but we're dealing with a population that we almost never dealt with hundreds of years ago. But how do we compare in the US to other countries? So this is life expectancy looking at 1980, starting from 1980 and going to 2021. So in general, life expectancy in the US is lower than in other developed countries. The chief contributor to that is that people have difficulty accessing healthcare. And then we've seen a drop in life expectancy in the US. Across the world, people saw a drop during the pandemic. We saw a more dramatic drop. The latest statistics say we're on a slow increase, but in general, in the US, we have a shorter life expectancy than in other developed countries. Looking at Clark County specifically and what we do in EMS, elderly patients are a huge proportion of who we see. So this is just looking at the ages of the patients that we saw in Clark County EMS over the last 90 days. And so, here, I'll point it out here. So, here is, here's age 65, and it's kind of where this curve starts to increase. And so, a huge chunk of the patients we see are about 65 to 85, and then it starts to drop off after there. But it's almost as much as all the patients we see under 65. So this is a huge chunk of what we do. So we'll go through the underlying conditions that develop in the elderly, and we're going to talk through it by body system. So the first thing we'll talk about is the nervous system. And in general, we'll follow a top-down approach through this. So one of the key things that we encounter in the elderly that's rare in other age groups is differentiating between delirium and dementia. This is the place where the history that you get in the pre-hospital setting is critical for making the diagnosis. So delirium is a transient alteration in consciousness. It tends to begin relatively suddenly and begins quickly. And so that's where the question is about, like, okay, is this person at their baseline, and when did they change? How did they change? People can typically point to a relatively defined starting point. It began a day or two ago, an hour or two ago. Not necessarily like a sudden thing like a stroke, but over a period of hours to days, whereas dementia is something that develops over months and years. So delirium is temporary and it's reversible. It causes difficulty with attention. So people with delirium have trouble tracking you in the moment. They can have alterations in speech. They're not following you like at the time that you're seeing them. Whereas patients with dementia, obviously this very gradual process, people in general have they're like, over the last few months, it's gotten worse, or, oh, she just seems to be declining over years. It is permanent, and it, people with dementia typically have trouble remembering recent events, but they can typically pay attention to you. They hear you talking to them. They can typically interact until it gets to be very, very progressed. Um, People with dementia are more likely to have, rather than slurred speech or altered speech, it just doesn't quite make sense. They can have trouble remembering things, and they can repeat things. They can confabulate. When in doubt, it's always safer to assume that you're dealing with delirium than dementia. But we point this out because it's just such a key part of the history that you take in the pre-hospital setting. Taking a closer look at the kinds of dementia that we deal with, there are two key points that I want to make with this slide, and then I don't want to get lost in the details. Key point of this pie chart on the left here is that the vast majority of dementia that we see is related to Alzheimer's disease. Next chunk is related to vascular dementia. There's people who either have had strokes or who have chronic small vessel disease, and the brain just gets, has an ischemic insult either in the moment or over time. There are many mixed kinds of dementia, and then there's some rare kinds like Lewy body dementia. There are a handful of others, Parkinson disease, and then frontotemporal dementia. And I'll talk a little bit more about that. So key point of that, the pie chart on the left, most of the dementia that we see is Alzheimer's disease. The point that I want to make with this graph that's on the left here is that there's some kinds of dementia that primarily have an effect on cognitive function, and there's some that have a much more pronounced effect on movement. And so just as you're getting the history from the patient and trying to put the picture together, understanding the background of some of this will help you to categorize what you're seeing in your head. So Alzheimer's disease, the most common, is primarily a mental process. There's relatively little physical consequence other than, if people exercise less, they get deconditioned. But there's relatively little physical consequence to Alzheimer's disease. Patients with Alzheimer's disease tend to stay, they tend to just not have these physical manifestations. Whereas patients with Lewy body dementia, they tend to be more independent. They can live fairly independently for some time, and the progression is slower. The kinds of vascular dementia have a little bit more of a physical component than Alzheimer's disease. The reason I mentioned frontotemporal dementia is that frontotemporal dementia and Huntington disease both have this lack of awareness, the frontal lobe is what inhibits your behavior and keeps you from doing stupid stuff. And so patients with frontotemporal dementia, Huntington's disease, they tend to have very little awareness of their disease, and they tend to do things that are quite irrational. And then, as I mentioned, so Huntington's disease, and then which is fairly rare, and then Parkinson's disease, they both have a significant movement component, and so you'll start to recognize that as you see patients kind of put patterns together. I'm going to go into a little bit more detail about Parkinson's disease. So it has a very typical appearance. So they typically begin with a resting tremor. So it goes away when they do something, but just at rest. And they have this pill rolling motion with their hands. Over time, the muscles become more rigid. They tend to have difficulty initiating their gait and then have this shuffling gait. They have a mask-like facies facies that they don't show much expression, especially as Parkinson's progresses. And so the pre-hospital management is to manage the treatable conditions, but these are patients that are at relatively high risk of falling because of the motor component. The other thing we deal with in the nervous system in elderly people is sensory impairments. So of those, the most common thing that we see is impairment in balance. That can be multifactorial. It can be because they have some peripheral neuropathy. It can be because of middle ear disease, something like Meniere's disease, which is a disease in the middle ear and causes vertigo. Obviously, many elderly people have hearing impairment and visual impairment. And so that both places them at higher risk for falls, for medication errors, but also makes it harder for us to communicate with them in the pre-hospital setting. We're going to move on to the cardiac system. So you can think of those as the change that happen in the pump and the changes that happen in the pipes. So as the heart ages, it tends to get stiffer and tends to get weaker. And so when it's stiffer, that's diastolic dysfunction. It doesn't relax as much as it used to, and so you don't get that the same squeeze out that you would to because you didn't get that initial relaxation. Systolic dysfunction is just it doesn't squeeze with as much force. Getting that history from the patient can help you to understand how they might respond to your treatments. In general, the most common reason we see diastolic dysfunction is because patients have lung disease. So the heart has been pumping against stiff lungs for a long time. It loses its ability to relax. So patients with COPD often have diastolic dysfunction. Most common cause of systolic dysfunction is ischemic heart disease. And patients have had an insult to their heart and then they develop dysfunction. In young patients, we'll also see systolic dysfunction from drug abuse, particularly methamphetamine abuse. I'm just going to point out some terms that get used interchangeably with systolic and diastolic dysfunction, so you're familiar with them when you see them on someone's record. So diastolic dysfunction is heart failure with preserved ejection fraction. Systolic failure is heart failure with reduced ejection fraction. And those terms are used interchangeably. They're newer terms, but you'll occasionally see those on patients' charts. So then what happens to the pipes? With the progression of age, you get atherosclerosis, and so the vessels get stiffer. So that leads to hypertension, leads to peripheral arterial disease, and then over time can lead to aneurysms. If you get a point where there's a particular pressure and it gets focused in that point, you can develop an aneurysm, such as an aortic aneurysm or an intracranial aneurysm. Those are the key changes that happen with the cardiac system over time. The end effect is that as people age, in general, you have decreased circulation. You both have decreased circulating volume, and then it circulates less effectively because of the changes in the pump and the pipes. The changes in the pulmonary system are similar in that the lungs just get stiffer. So you get increased stiffness of the chest wall, decreased muscle mass, which makes it which makes breathing less effective. You get reduced mucociliary clearance, in other words, your ability to clear junk out of the lungs, fight off infection. You get decrease in the elastic fibers, and you can get enlargement in the alveolar ducts. and the alveoli. In general, people who don't have exposures to things that make the lungs age tend to do fairly well. But it is if someone, obviously the chief thing we see is smoking that ages the lungs, but then there are also occupational hazards that put people at risk for lung disease. There's asbestosis is probably the one that we see most common. There's coal miner's lung. Um, and then there are a handful of autoimmune diseases that cause lung problems as well. But in general, with older lungs, you see stiffer lungs and decreased ability to get air in and out. In the GI system, it's a busy slide, but I'm going to point out the things that really matter here. So one of the key changes in the GI system is you get decreased gastric absorption. So that can affect absorption of meds. It can contribute to malnutrition. With the oropharynx, you get impaired neuromuscular coordination, especially if you're dealing with a motor dementia. And so older patients are at risk for dysphagia and aspiration. Aspiration can lead to aspiration pneumonia. The key change in the liver is that it changes drug metabolism. So remember that most drugs are either cleared through the liver or cleared through the kidneys. And so having changes in liver function can alter your drug metabolism and increase your risk of adverse reactions or drug interactions. And then as we move further down the GI system, the biggest thing that we see with age is you get an increased risk of bowel obstruction. The key risk factor for bowel obstruction is having surgery. It's rare to have bowel obstruction if you haven't had prior abdominal surgery. Crohn's disease is also a huge risk factor for bowel obstruction. Moving on to the urinary system. Similarly, you have decreased filtration, and so that decreases your clearance of renally cleared drugs. So that's one of the key things that they have to think about in elderly patients. You also increase the risk of obstruction. For urinary obstruction in men is most commonly caused by prostate issues, usually BPH or benign prostatic hyperplasia. Other prostate cancer and other issues can cause obstruction in men, or urethral stricture can cause obstruction. In women, women can have obstruction, more common to have incontinence, and there's a higher risk of bladder infections just because the urethra is shorter. With respect to the skin, over time, the skin, as you've all seen, it tends to get thinner, it tends to get more fragile. As there's poorer perfusion, and so obviously higher risk of skin tears, even with minor trauma. And then one of the things that tends to be sneaky that we really want to catch, is another place where the pre-hospital history really helps, is decubitus ulcers. They can cause significant morbidity, can be a source of infection. So they're typically from the waist down, typically over places where the bones protrude, like the sacrum, the hips, the heels, and typically in patients that are bedridden. And so one of the key things, because we won't, if we're walking in to see someone in a bed in the emergency department, we won't always know, like, does this person walk at home? And so that's a key piece of the history as far as the risks to the patient's skin. With respect to the musculoskeletal system, you get atrophy of the muscles, the tendons tend to shrink and harden. Patients with osteoporosis will tend to lose height over time because they lose bone density, get increased kyphosis of the spine. And so with all that, there's an increased risk of fractures. Osteoporosis is more common in women than in men because of hormone effects. And the things that are primarily a risk on osteoporotic fractures are vertebral compression fractures, most commonly in the lumbar spine, although you can have them thoracic and cervical as well, and then hip fractures. And these are obviously they're at higher risk with a fall, but you can have an osteoporotic fracture even without any trauma. If there's significant osteoporosis, you can have with no significant trauma, you can have vertebral compression fractures, and you can even have hip fractures without trauma, because those are the places where the bear the greatest portion of the weight, and so if they lose bone density, they're at risk for fracture. And then taking all this together, the last thing I'm going to say is that there's a significant decrease in the ability to adapt to environmental changes. Hypothermia is something that we can see occasionally, particularly in people who don't have reliable heating, and in the elderly can present with fairly non-specific complaints. There can be an initial period of hypertension and tachycardia, but ultimately they tend to become bradycardic and ultimately hypotensive. And an elderly patient with hypothermia often doesn't shiver. It's another place where the pre-hospital history about the environment is really critical. The thing that's probably a greater threat is hyperthermia. And we have seen with heat waves, significant excess mortality in the elderly, and particularly in an area like ours where many houses don't have air conditioning. A heat wave can and has it turned into, in effect, an MCI for older people. And so, again, it's another place where understanding the environment, understanding what you see when you get on scene is really critical. The key changes in the sweat glands, increased heart disease. They just can't manage the heat as well. And then any other risk factors, any comorbidities, can put them at risk for hypothermia. And again, it doesn't have to be 110 in the house. It can be 85 in the house, but over time, people can develop significant heat-related illness. Okay. Any questions about systemic changes before we move on to stuff doctors do to people? Okay, so moving on. So now we see this increased elderly population. A huge reason that we see that is because of improvement in sanitation, basic public health. But there are things that we do that can help people live longer, but they also put people at risk for different pathology. It's no surprise that probably the first on this list is anticoagulant and antiplatelet drugs. So why do we do which? What are the difference? So antiplatelet drugs inhibit platelet aggregation. In general, patients on antiplatelet drugs, they rarely just start bleeding spontaneously, but if they do start bleeding, they have a harder time forming that initial clot. As a rule of thumb, antiplatelets are prescribed for patients with high velocity disease states that affect arteries. So cerebrovascular disease, coronary artery disease, peripheral arterial disease. We'll go into more depth about the different antiplatelets. And then anticoagulants inhibit the clotting cascade at one or another point. They're typically prescribed for low velocity states that involve the left atrium and involve the veins. So pulmonary embolism typically starts from a deep vein thrombus in the legs that travels to the lungs. Atrial fibrillation places patients at risk for clot. And then obviously DVT or something that we treat with anticoagulants. There are different kinds of antiplatelets and anticoagulants. Again, I don't expect you to know or remember all of this. I just wanted you to be familiar with the names. And then in the next slide, we'll go into some of the brand names. So in general, COX inhibitors like aspirin and other NSAIDs have an antiplatelet effect. Just one brief note, meloxicam or Mobic is the one NSAID that doesn't have significant antiplatelet effects. And that's why the military uses it as its preferred NSAID. There are GP2B and 3A inhibitors. These are typically things that are given to patients right around the time of PCI. The P2Y12 inhibitors tend to be more powerful antiplatelet drugs. The one we see most commonly is clopidogrel or Plavix. And then there are phosphodiesterase inhibitors. Most common of those is dipyridamole. With anticoagulants, there are ones that work directly on thrombin. Most common one we see in the outpatient setting is dabigatran, Pradaxa. They're indirect thrombin inhibitors. These are typically used in the hospital. Occasionally, patients will be discharged with injectable enoxaparin. Direct 10A inhibitors. The reason I mention this is that it's an easy way to identify an anticoagulant drug. These drugs all have XA in the name because they're 10A inhibitors. So most common ones are apixaban and rivaroxaban. And then there's also warfarin, which is a vitamin K antagonist. But we're just seeing that less and less frequently now because the direct 10A inhibitors, you don't have to check, you don't have to do any lab monitoring. They work more reliably and have fewer interactions. And so just to go a little bit deeper into some of the brand names, the ones that you'll see most commonly, you'll occasionally see outpatients on Agrinox, which is a combination of dipyridamole and asthma. Brilinta, ticagrelor, again, is one of those that's given around the time of PCI. Everyone's familiar with Coumadin and warfarin. Heparin is an in-hospital medication. Prasugrel is another one that's given around the time of PCI. Eliquis or apixaban is a very common outpatient anticoagulant. We talked about Plavix or clopidogrel. Cilostazol is not commonly seen outside in the outpatient setting. Pradaxa or dabigatran is relatively commonly used. And then Xarelto or rivaroxaban is another very common outpatient anticoagulant. The other class of medications that have some of the most significant side effects for elderly patients are beta blockers and calcium channel blockers. So they both have their desired effect and they have unintended side effects. The beta blockers, ending in OLOL, obviously decrease chronotropy, inotropy. But they have the side effects, as we expect, bradycardia, but they can also cause lethargy. They can cause GI disturbance. In patients with asthma, they can contribute to asthma or make asthma harder to treat because we treat asthma with a beta agonist. And about 10% of patients on a beta blocker will experience depression. Calcium channel blockers, the outpatient ones we see are verapamil, nifedipine, diltiazem, most commonly. Also decreased contractility and conductivity. Their side effects, obviously, we expect them to decrease blood pressure and cause bradycardia, but they can cause headache and they can cause peripheral edema. There are a lot of drugs that we prescribe that have effects on the central nervous system in the elderly. And so I've highlighted the ones that clinically are the most important. Obviously, benzos have an outsized effect in the elderly. They're primarily cleared by the liver, and so they can really accumulate. And so it is fairly rare to see elderly patients on regular benzodiazepines. And if they are, that can be a significant contributor to altered mental status. Obviously, opioids can have increased CNS effect in the elderly, and that's primarily because of their decreased clearance. The other one we see clinically really often are antibiotics. And the fluoroquinolones like ciprofloxacin, levofloxacin are probably the biggest contributor. And so, a pretty common call is, she had a UTI, she's not getting better, she's getting more goofy. But patients on fluoroquinolones, not uncommonly, will become altered just because of the fluoroquinolone. So we try to avoid those whenever we can. And then anything that has a anticholinergic effect can cause altered mental status in the elderly. So there are drugs like diphenhydramine or meclizine that are prescribed for vertigo, but probably the most common drug that we see in this class that causes altered mental status in the elderly is Benadryl or diphenhydramine. That's a very common cause of altered mental status in the elderly. Antihypertensives can also cause some altered mental status, but that clinically that's less common. Now, particularly with antibiotics in mind, one of the things that we're seeing in elderly patients is the emergence of multi-drug resistant organisms. And the patients where we most commonly see these are elderly women who are prone to urinary tract infections or prone to poor use of antibiotics or overuse of antibiotics. Every time we treat an elderly person for a urinary tract infection that might not actually be a urinary tract infection, we put them at risk for developing multi-drug resistant organisms. So some of the common ones, everyone's familiar with MRSA. We've also seen some vancomycin resistant Staph aureus. There's vancomycin resistant Enterococcus. And then I point these last two out because the last two relatively common, and it's a case where it really matters using contact precautions because these are things that are hard to get rid of. So everyone's familiar with C. diff. It's typically associated with antibiotic exposure, and it's called C. diff because it can be extraordinarily difficult to treat, and patients typically need multiple courses of another antibiotic, usually oral vancomycin, to get rid of it. And then the thing we've seen emerging over the last several years are the gram-negative multi-drug resistant organisms. And these are really scary because, whereas MRSA lives on your skin, as long as you keep the skin intact, you're probably not going to have significant problems with it. The gram-negative multi-drug resistant organisms that live in your gut, your intestinal flora is essentially populated with these bugs that don't respond to multiple antibiotics. And so you can see multi-drug resistant E. coli, Klebsiella, Pseudomonas, Acinetobacter. And so if you see this on a patient's chart, definitely a reason to use contact precautions because these things are relatively easy to spread and they can be very, very hard to treat. Another thing we see in the elderly that we contribute to as doctors is polypharmacy. And so the risk factors for developing polypharmacy, obviously being elderly, having the decreased drug clearance, the more comorbid conditions you have, the higher risk you are for polypharmacy. Recently being in the hospital, it puts you at high risk for polypharmacy because if there's any error in medication reconciliation or any confusion about the medications, patients can be taking excess medications. The more physicians are involved, that obviously increases the risk for polypharmacy. And so you really want a primary care doctor who is coordinating that and doing everything they can to eliminate unnecessary medications. Having multiple pharmacies also puts patient at risk for polypharmacy because a pharmacy will check for drug-drug interactions and we'll look at the whole medication list. Obviously, any inappropriate medication we prescribe and any poor documentation that we have. And I think the thing that happens most commonly now is that with everyone locally being on Epic, you have these multiple drug lists, and unless you as a doctor take the time to go through them, it's really easy for an error to creep in. And then elderly patients can also have poor adherence to the medical plan. Um, it can be confusion, can be from self-medication, either from a neighbor, over the counter, or herbals. Um, we can see patients who shop for doctors in order to get the prescription they want. And then the problems with compliance because of cost. One of the problems, patients over 65 in general are eligible for Medicare, but unless you opt in at age 65 to get drug insurance as well, drugs may not be covered. And so that puts patients at risk for not being able to afford their medications. And we've seen big price fluctuations, especially with insulin recently. And then patients may skip doses to save money. They may forget. They can't read the label, or they can't open the bottle. The other things that put patients at risk for not taking their medications as directed. Living alone, obviously not having anyone who can check that. Any dementia contributes to that. Obviously, alcohol or any other substance abuse. No insurance, particularly no drug insurance. Not having a primary care doctor. Again, as we talk, can contribute these things to these things. Patients can become depressed or feel frustrated because they want the medication to work and it hasn't worked already. And then patients on a fixed income have, it's not like they can work an extra shift to be able to afford their medication. Any questions about the stuff we as doctors do to people? Okay, so I'll move on to talk about practical considerations. And so with this, we're going to focus on sepsis, trauma, and abuse and neglect. So with sepsis, the symptoms of infection in the elderly can be difficult to pick up. The inflammatory response can be blunted, and so sometimes we only see relatively subtle findings, and we get these subtle vital sign clues. But they, unlike a young person, for example, with pyelonephritis or pneumonia, that can pretty clearly describe their symptoms. It's more likely in an elderly person for these things to kind of sneak up. The most common source of sepsis that we see is respiratory, and then urinary tract infection next most common after that. That's another place where getting the history, and if there are multiple people in the house who are sick, that can help us come to a clue. So any patient with the potential for an infectious process, we want to make sure that we're considering sepsis. Just a brief review of protocol. So universal patient care protocol, oxygen saturation above 95%. And so sepsis is a known or suspected infection with any of the signs of SIRS. So a temperature greater than 38 or less than 36, a respiratory rate greater than 20, heart rate greater than 100, and tidal CO2 less than or equal to 25 millimeters of mercury. So if you have signs of septic shock, meaning a systolic of less than 100 or a MAP less than 65, or if you have altered mental status in the setting of a suspected infection, then that's sepsis alert, and those patients are transported with red acuity. Give fluid until you get to a MAP greater than 65, or neck vein distension, or rails. If they're not responding to fluid and the MAP is still less than 65, start norepi with the goal of MAP 65. You have epinephrine as an alternative. If you have a patient that is normotensive, so MAP greater than 65, not altered, those patients can be transported with yellow acuity. I mentioned urinary tract infections are a common source of sepsis, typically caused by the bacteria that live in the GI tract, and they can lead to urosepsis. It is, obviously this can be difficult to sort out, but we don't treat for a urinary tract infection unless we have signs of a urinary tract infection. So even if we find bacteria in the urine, but there are no signs of infection, then we don't treat that with antibiotics because of the risk of developing multi-drug resistant organisms. What are the signs and symptoms of a urine infection? Urinary urgency and or frequency, low abdominal pain or flank pain. It can be an unexplained fever. If you have signs of a urinary tract infection, you have septic shock, then we presume urosepsis. But to note, foul smelling urine by itself is not enough for us to make the diagnosis. And urine typically smells foul because patients are relatively dehydrated and it just tends to get really concentrated. So we need to see, to make the diagnosis, we need to find bacteria in the urine, plus have symptoms that fit with the urinary tract infection. Now, obviously, there's some patients that are just so altered we will presume, but we want to limit the times that we do that so we're not using antibiotics inappropriately. I'm going to move on to talk about trauma. So a leading cause of death in the elderly. The risk factors are osteoporosis, the reduced cardiac reserve, the decreased respiratory function, impaired renal function, decreased elasticity in the peripheral blood vessels. Blood pressure and pulse can be delayed indicators, and if we have even transient hypotension, that's an important indication that this is significant trauma. They can have decreased perception of pain. An altered mental status in the setting of a trauma, we have to presume is related to the trauma and in hypoperfusion. With respect to head and spinal injuries, the differences in the elderly. So as you get atrophy of the brain with age, you get more space. And so the bridging vessels have to cover more space. So elderly patients are at higher risk for intracranial hemorrhage. And then because of osteoporosis, they're at higher risk for fracture. Just one brief note, especially patients with rheumatoid arthritis are a particular risk for having a fracture of the dens, the process of C2. Okay. With respect to transport, so we modify the positioning, we modify our spinal motion restriction as needed to achieve the intended effect. Remember that elderly patients are at risk for hypothermia, so package them in a way that retains body heat. And then last, because of all the things we've discussed previously, geriatric patients are at risk for abuse and neglect. I think that, the signs of neglect are fairly straightforward. It's another place where the pre-hospital history is critical because how the house looks is an important sign to how well the patient is being taken care of. But then there are obviously the signs on the patient. Are they bathed? Are their toenails clipped? Are they, are they well nourished? Remember, as you look for signs of abuse, it can be emotional abuse, there can be physical abuse. And so similar to with children, we can see, bruising in various stages of healing. But the one thing that elderly patients are particularly susceptible for is financial abuse. And so, keeping that in mind as you assess the situation, if someone has resources, but the person who controls the money isn't releasing them, that can be financial abuse. General, better not to confront the family in the moment. Just document your concern and report it to the receiving hospital and to APS. Any questions about sepsis, trauma, or abuse before we wrap up? Okay, so I'm just going to review some take-home points and I'll ask for feedback. So consider these underlying risk factors as you're assessing the geriatric patients. think of the changes by system and how they might respond differently to younger patients. Think about the risks that the patients are exposed to because of the medical treatment that they're receiving. Use caution as you're dosing drugs in the elderly, and in general, just going with a lower dose, dosing somewhat more slowly is in general a safe approach in the elderly. And then be alert for hidden sepsis, for trauma, even with minor falls, and for abuse and neglect. That's all I have. I'm going to post the link for feedback in the chat. I really value your feedback. Yeah, we want to make these lectures the best we can for you. That I'll take any other questions, and I appreciate your time and attention.
Dr. Macht?
Yes.
I'm just going to put in a list of the 10 top reasons that elderly call 911. See if I've got this in here yet. Let's see. All right, hopefully that'll come in. It's in order, descending order.
Are you posting it in the chat?
It's in the, it should come into the chat. Yep.
Haven't seen it appear yet.
It's in my chat. I can see it in my chat, so. This is an excellent presentation.
Thank you.
One thing we should mention is that for the elderly, we've moved and you alluded to it, we've moved the systolic pressure to qualify for a trauma entry has moved up from the previous level. It's moved up to a much higher systolic pressure or MAP, so that basically trauma, a patient, an elderly patient with a systolic pressure of 100 or less is clearly hypotensive.
Mm-hmm.
That will buy them a red return to the hospital for trauma entry.
Yes. Dr. I still haven't seen your list appear in the chat. If you want to send it to me, I can post it.
I'm surprised that because I type it's looking perfectly on my. I wonder if I can send it again. It's listed in, and I've already gone on to type a new. It's right under excellent presentation. And then I've got another. I'm listed. I'll send it, and you can post it on the thing. It's a list actually from. It's Hennepin County's current top 10, but I think it meets our. It fits with our county too, and also note that 30% of EMS calls in the Minneapolis, St. Paul area involve elderly, and that would be about looking at what we've got too from your data.
Dr. Gadbois, I see your hand up.
Yeah, I was gonna say that that I can see that it's not a true like bullet pointed list, but it's kind of a continuous comment from Lynn in the chat.
Okay. That might be an issue on my end. Anyway, we'll share that. So if there are no other questions.
Yeah, for speed, my typing ability says for speed, I just put a semicolon between each one, but it's and for congestive heart failure, it's not heat failure, congestive heart failure. It's really pulmonary edema and that's the number 4 cause next to pneumonia, which is number 3. And that's an interesting thing because it's difficult sometimes to determine whether you have pneumonia or congestive heart failure, and it requires a little bit of it requires history and weighing more than just the physical findings, and then sometimes they have both. So the treatment is pretty much the same, at least pre-hospital wise. Any rate, it is on there. I'm glad it showed up at least on somebody's thing. So I will send you another list of it if you will like separately, or if you can't find it.
No problem. And we'll share to make sure everyone has access.
Okay, good.
Any other questions or comments? Okay, we'll go ahead and wrap the presentation. Again, we do take all the feedback seriously. We want to make this the best presentation possible. And I appreciate your time and attention. Have a good rest of your week.
Thank you, Dr. Mock.
Thanks, Dr. Mock.
Thank you.